Greetings. Let us learn about the technique of submucosal injection using either methylene blue or indigo carmine. So let us look at the different dyes that are available for this purpose. One, methylene blue, which is an absorptive stain, and two, indigo carmine, which is not an absorptive stain. If you have the choice between the two, it is preferable to use indigo carmine, which is not absorptive stain, and it gives you some freedom and flexibility. How do you prepare the submucosal solution for injection? And although there are a number of different companies that produce ready-made submucosal injection solutions, it is simpler to make a solution yourself, and for that you need saline, a 10 cc syringe of sterile saline and indigo carmine, and add 1 drop, and that will turn the saline to sky blue color or Carolina blue color. And that's the color you want to see. And when you look at the syringe, you should be able to see the numbers on the syringe from the other side. So for a small polyp resection, 10 millimeters, 15 millimeters, you should be able to do with 1 10 cc syringe. On the other hand, if you have a large polyp for resection, 20, 30, 40 millimeters, then it is preferable to take a 100 ml bag of saline and add 10 drops of indigo carmine. That will give you the same color that you would expect to have. In terms of the size of the syringes for injection, the best size is a 10 cc syringe that gives you the best outcomes for submucosal lift with submucosal injection. When it comes to handling an injection catheter, the first step, whenever you use any fluid for injection, it is to clear the bubbles in the syringe by making the syringe, nozzle up, and then making sure that you clear all the bubbles by plunging on the plunger, and then take the injection catheter and prime the needle with solution so that there are no bubbles in the injection catheter. So priming the catheter is critical. Otherwise, if you forget to prime the catheter, when the endoscopist uses the needle to puncture, he will create a gas bleb. So once you prime it outside and you prime it again in the lumen once the needle is out. I typically ask my endoscopy assistant to flush, and I want to see two things: whether my catheter has been primed or not. And in addition, I also use this to figure out whether the lesion is dependent or non-dependent. And this is important because if the lesion is dependent and you don't make changes to make the lesion go non-dependent, and you cut, and if there were to be bleeding, you may not find that bleeding vessel as the vessel gets submerged under a pool of blood. So something to keep in mind. The priming of the needle catheter helps you to confirm it's been primed, and it also helps you to figure out whether the lesion is dependent or not. So let us learn about how do we go about injecting to create a nice submucosal lift of a polyp. So here is a polyp, and it's important to make sure before you do anything, you ask the assistant to get the needle out first, and once the needle is out, then you make the needle puncture of the submucosa. And once you punctured in, I always ask my assistant to gently tap on the plunger. And that gentle tap would squirt only a small amount of saline, and you will see a fluid cushion develop. And once you're satisfied that you are in the submucosa, the assistant could inject further at a rapid pace. The pace of injection should need to be adjusted depending upon the type of polyp one is looking at. And it's also important, as the injection is continuing to create the lift, the assistant should get into the habit of saying loudly how much fluid has gone in. You should say 1 ml in, 2 ml in, 3 ml in, so that the endoscopist knows how much of fluid is being delivered into that submucosa. So this is a good submucosal lift. So we have learned about 3 important principles in submucosal injection. Number 1, get the needle out first before you puncture the submucosa. Once you puncture, the assistant should not inject fast, but gently tap on the plunger, tap, so that it helps the endoscopist figure out whether he is in the submucosal plane or not. And number 3, the assistant should count loudly the amount of fluid that has gone into the submucosal plane. And these 3 principles are essential for a good submucosal injection technique that will result in a great lift. Let us learn about some of the things that you don't want to do, and these lead you into trouble. So here is the injection catheter out of the scope. The needle is not yet been has not yet come out of the catheter sheath. I have seen some endoscopists who would say needle out and inject, and what happens is the needle can go through and through the colon wall, and the assistant may deposit a lot of fluid into the peritoneal cavity. So it's important to avoid this problem. So this problem could be avoided by taking the step of having the needle out before puncturing, and number 2, the assistant getting into the habit of tap, so the small squirts are delivered. Number 3, counting loudly, 1 ml, 2 ml, 3 ml, etc. If you follow that, you're always going to go, the procedure will go well, you'll have a good outcome. On the other hand, if you have the catheter and the needle is not out, but you tell the assistant, needle out and inject, it will result in an extramural injection. And sometimes this bulge can give you the impression that you had a good lift of that lesion, and in fact, that lift was from the extramural bulge, and it can lead to trouble because your cautery injury will go through and through without that submucosal cushion to buffer it. So if in case, even if you've taken the needle out and punctured, and you did not create a submucosal bleb, but it was extramural, because the assistant has been saying, hey, tap, and then I've injected 1 ml, 2 ml, but you don't see a good lift, then you should suspect it was an extramural injection. And in that case, you should ask the assistant to stop injecting and you gently pull the needle back slowly, and as the assistant taps to find that submucosal plane and then inject. It is not a good idea to pull out the needle completely and find another slot. Sometimes it may cause unnecessary leakage of fluid. How about fixing a mucosal blep that can happen if a polyp has been cut before and it resulted in scarring? So here is a polyp, needle out, inject, and then it resulted in a mucosal blep. These tend to be very superficial. You can see the thin mucosa, and if that's the case, don't pull the needle back. Instead, ask the assistant to stop injection, and the endoscopist should puncture a little further, get into the submucosal plane, and create the blep. So we have learned the principles of submucosal injection technique, and I want to stress the importance of two important techniques in submucosal injection. The technique of tap on the plunger of the syringe so that the assistant in the initial phase of the submucosal injection delivers small squirts of fluid. And number two, the assistant should get into the habit of counting loudly the amount of fluid injected. 1 ml in, 2 ml in, 3 ml in, and the endoscopist can see whether he is in the submucosal area and is getting the appropriate lift from the volume of fluid that is going in. So let us learn this thing again. So here is the steps that you will see outside. The catheter is outside the scope in the operating field. The needle is out, and the endoscopist pushes the needle down to make the puncture, and at this time he will ask the assistant to tap, and that will result in a good submucosal lift if the needle was in the submucosal plane, and then he can ask the assistant to continue injection, and as the injection is going, he will try to pull the needle back to give space and lift the tip up so as to get a good submucosal lift. So here we flushed. Let me show this principle again in this video. So we prime the needle, and we got the needle out of the catheter. We puncture, and we ask the assistant to start injecting. As you can see, he's tap, and you can see a good lift happening. And that's how you will get into the submucosal plane and get a good lift that allows a successful endoscopic mucosal resection. And I hope this is helpful. And there are small things that you want to keep in mind. Get the needle out before the puncture. Once you puncture, the assistant should get into the habit of tap, and also count loudly the amount of fluid delivered, 1 ml, 2 ml, 3 ml, etc. I hope this is helpful. Thank you.